Cast is now starting. All attendees are in listen-only mode.
Good afternoon and good morning, everyone. We're going to give attendees about 3 more minutes to join, and then we'll get started. Thanks.
There's only a couple places.
Hello, everyone. We're going to give everyone about 1 more minute, and then we'll get started. Thank you. Good afternoon, good morning, everyone. Welcome to today's webinar, Pathways to Success, a new start for Medicare's ACOs. My name is Nathan Brown. I'm Director of Marketing at SpectrumMedics. I'm going to be the moderator today. A few housekeeping items before we get started. If you have any questions during the webinar, please enter them into the question field of your control panel. We're going to be answering questions at the end. And we're going to be conducting 3 polls today. So if you could take a minute to answer, we would appreciate your feedback. So today's speakers, the star of the show today is Mark Rucci. Mark is ACO Product Manager for SpectrumMedics. He's former MSSP ACO CEO as well. And myself, Director of Marketing, Nathan Brown. Mark, a little background on Mark. Mark has 35 years of experience providing healthcare analytics, actuarial, claims audit, and benefits consulting services to self-insured employers and healthcare provider organizations. And before coming to SpectrumMedics, Mark served as the president of Partners in Care Corporation, a physician-owned IPA with over 700 physician members in New Jersey, where he managed the Partners in Care ACO, a Medicare shared savings program ACO with 15,000 assigned beneficiaries. So that's a little bit of background on Mark. A little bit about us, Spectrumetics. Our platform powers the transition to value-based payment and actionable insights and demonstrated performance improvement across the healthcare system. So we impact over 1 million lives. Our applications support Medicaid, Medicare, health plan, ACO, and hospital performance improvement initiatives. The platform is created for the nuances of healthcare provider and payer business requirements. And finally, the platform in our company is powered by a crew of seasoned clinicians, technologists, and informaticists with deep healthcare experience. This is a graphic of the Spectrumetics platform. It shows a little bit about what it is and what it does. Basically, we take in, we aggregate and work with many data points, EHR, HIE, claims, social determinants of health. We take in data in structured and unstructured format. We populate an enterprise data warehouse. We've also built an EMPI, Enterprise Master Patient Index, to match and harmonize data. And then from there, we help providers and payers use their data to implement hospital and ambulatory programs, like on the left here, hospital and ambulatory measure and performance improvement programs, such as HEDIS and DISRIP, ECQMs, MIPS. And then also, we help them with a range of initiatives and programs around population health, such as ACO management, which we're going to talk more about today, of course, Medicaid and Medicare management, risk stratification and adjustment, and other VBP programs. So enough about us. The agenda today, why the change, and then new ACO participation options. We're going to talk about other key provisions, and then key questions to consider moving forward. So before I hand it over to Mark, we're going to conduct our first poll. In what type of agreement or agreements does your ACO participate? You can check all that apply. I'm going to launch the poll now. Give everyone about 30 seconds to answer. All right, going to close the poll and share the results. So 71%, as you can see, chose Medicare. Second was 35% with Medicare Advantage, and then commercial 24%, and then 29%, I guess, does not apply right now. All right, thank you, everyone, for participating. And I'm going to hand it over to Mark.
All right, good afternoon, everyone. So we're here to talk today about the proposed changes made by CMS for the Medicare Shared Savings Program. Just to get everybody to the same level, hopefully this is review. The Medicare Shared Savings Program was part of the Patient Protection Act signed by President Obama and launched in July of 2012. Currently, there's 561 Medicare Shared Savings ACO serving 10.5 million fee-for-service beneficiaries, which is more than a quarter now of the fee-for-service beneficiaries in Medicare. So a very substantial program and a key component of CMS's healthcare reform and transition to value-based payment. So because of all of that importance, CMS has reviewed the experience of the program to date, and on August 9th issued a proposed rule that would do a full overhaul to the program, changing just about everything. Very substantial changes, and that's what we're going to talk about today. These changes are mostly effective July 1st of 2019, with a few exceptions, but generally everything I'm talking about today is going to go into effect 2019, and I will talk about the timing a little bit later. So why the changes? From CMS's view, they looked at the experience of the program to date and came to the conclusion that the program was actually increasing spending for CMS, for the Medicare Trust Fund, rather than saving money as predicted. Most ACOs were taking the option of track one, which was the one-sided only, no downside risk option, and maximizing their time there, which in the current model is 6 years. And that is true. So they looked at that as a finding. So therefore, the opposite of that is the participation in the two-sided risk models was very modest. It's very small. Currently, 92% of the ACOs are in track one that are in the Medicare Shared Savings Program. They've also decided that because of the lack of savings in their opinion, and I'm going to come back to that, the track one upside only program does not provide enough incentives to generate savings. They're looking at the results and saying, if everybody's in track one and we're not getting savings, there's not enough incentive there. The incentives of losses are necessary to generate savings. They do believe that the two-sided model, though modest participation, has been more successful in generating savings. So they're putting all that together. Then they've also come up with this new concept called low and high revenue ACOs. I'm going to define that a little bit later in the presentation. But basically, low revenue ACOs are physician-led ACOs. They've decided that they perform better than high revenue ACOs, which are ACOs that generally have hospitals as participants directly in them. And again, I will define that a little better for you. They're actually coming out and drawing a line between low and high revenue and making a difference, and believe that the high revenue ACOs are to be treated differently as we go forward. So again, why the change? This is a quote from CMS Administrator Seema Verma. She's had a lot of quotes. She has a blog out there, if those of you don't follow. She's been very vocal about these and posted a lot of items in the public domain. But she did put a quote out that the changes were necessary because the weak incentives of the upside-only program, if you will, has led to increasing costs, and that they need to put a stop to that is essentially what she's saying. So that's CMS's point of view. Right or wrong, that is the motivation CMS used to come up with and to advise these policy changes. So let's look at the evidence. This is a chart of the net savings to CMS. Net savings being the gross savings to the program. This is being measured off of the same way that the benchmarks and the shared savings are measured to an ACO. So net savings is the gross savings, in other words, the actual expenses below benchmark, and then netting out any shared savings payment back to the ACO. So it's the net savings to Medicare, net of the bonus payments that were paid out. So the CBO projected in the beginning of the MSSP that there'd be substantial savings by the line on the bottom, the black line that's decreasing on the bottom half of the chart. It's very significant savings were projected. The blue line is the actual net savings through 2016, and being above the line, it's actually negative savings or costs to the Medicare program. And these numbers are accurate as much as we know, but are measured in terms of the savings, the way that we measure for the benchmarks. At the end of the presentation, I'm going to present some alternative ways to look at that. But this is what the evidence that CMS used to say that the program is not performing the way they want it to. And there is evidence. We do know that most of the ACOs are in track one, the big blue portion of the pie chart. That is true. About 92% of the ACOs currently in track one, and that most of them are now in their second agreement, and those second agreements are coming to expiration. So part of the timing of this announcement, if nothing was changed, at the end of those second agreements, those track one ACOs would need to select and move on to a two-sided risk program in order to continue. So it's very timely that we have a large number of those ACOs coming up for that period of time, and hence the timing of these changes. And then to go with the ACOs, of course, the majority of the participants, the beneficiaries who are assigned to the ACOs, the vast majority of them, 8.15 out of the 10 million, are in the track one, assigned to a track one ACO. So we do see that and do agree with all that. So CMS took all that evidence and developed a program with the following goals: a more measurable move to value. That is a roadmap to two-sided risk. They want to demonstrate savings to the program. They want to promote additional accountability and accountable care by accelerating the move to two-sided risk. Currently, as we said, that ACOs can participate for 6 years before moving to two-sided risk. That's going to be accelerated. And again, a new concept, they want to promote competition by encouraging participation by low revenue, as I said, generally physician-led ACOs. They believe that those ACOs are actually, in some cases, the high revenue ACOs are stifling competition in Medicare's point of view. That's a new concept, not necessarily something we agree with, but those are the motivations that CMS had in making these changes. So the first thing is that the major change is that the participation options, the tracks that are available to participate, are going to be drastically changed. To remind everybody, the current tracks, we have 4 options: track 1, 1 plus, 2, and 3. And to be technically correct, tracks 1, 2, and 3 are part of the MSSP. Track 1 plus is technically a CMMI time-limited initiative, but we all loop with, for purposes of this discussion, we're looping all that together, and the Medicare changes affect that as well. So we're going to call all of that MSSP. But for those of you who are sticklers for the truth, I wanted to make sure we understood that. So we have track 1 being the only one-sided option, where you share 50-50 in the savings. And then we have tracks 1 plus, 2, and 3 that have increasing amounts of risk, with increasing shared savings opportunities in exchange for that increasing risk. I do want to point out from this graph chart that under the current program, all of the two-sided tracks qualify as advanced APMs under MIPS, under the Quality Payment Program. So they actually are exempt from MIPS and get a 5% bonus, and the participants do not need to participate in MIPS. That's going to be very different when we look at the new tracks, so keep that in mind. So what's going to happen? Step 1 is tracks 1, 2, and 1 plus are all going to be canceled, effective July 1st, 2019. In addition, if any of you took the deferred renewal option, which gave you an extra year at upside risk, and then moving to your track to your two-sided risk agreement in the next period, that is also being canceled. Next gen ACOs and the CEC or ESRD model ACOs are not affected by these proposed changes. So instead of the 4 tracks that we have today, CMS has proposed what they call 2 tracks, a basic track and an enhanced track. And you'll see some of the parameters here in front of you. The basic track actually has 5 levels within it. So they're calling this a move from 4 tracks to 2 tracks, but really it's a move from 4 to 6 the way we look at it, because the basic track has 4 levels that you will participate in over time. The 5 levels. The 5 levels are what CMS calls the glide path to risk. Levels A and B are one-sided, and they are upside only risk. Levels C, D, and E go two-sided and have increasing levels of risk. So each one of these levels an ACO can only participate in for a maximum of 1 performance year. So if you start at level A new ACO could start at level A, have 2 years at one-sided risk, and then would go to downside risk in year 3. So first big thing to note is we no longer have the opportunity for 6 years of one-sided risk. The maximum is 2 more before you go to downside risk. Now the level E is equivalent to what is currently track 1A. So the lowest level of downside risk. The good news is we have this track. So levels C and D are new, lesser levels of downside risk that are below what we currently have now as 1A. So we do have this glide path, but the glide path under the basic track is finishing where 1A is now. The enhanced track is simply track 3 currently renamed. So the enhanced track is track 3, level E of the basic track is track 1A, and the other tracks are new. Items to note is that other than only getting 2 years of one-sided risk, you'll notice in the first blue shaded row, the shared savings percentage has been dropped during those 2 years from a 50-50 savings, shared savings, to 25-75. So new ACOs will not have currently have 6 years of 50-50 shared savings, and under the new program would only have 2 years of 25-75 savings. That's a big change. You can see then when you go to downside risk that the upside savings we go from 30 to 40 to 50%. So as you accept more downside risk, you get more upside potential to offset that. But of course, everybody focuses on the downside risk and have that exposure. And again, the enhanced track is simply track 3 renamed. The other thing that mitigates that risk, which is a positive thing from the ACO's point of view, is that the shared savings payment limit at the bottom of this screen is 10%, except for track 3 or the enhanced track, is 20% as it is now. But if we look at tracks 1 plus 2 and 3, they went from 10 to 15 to 20% as the maximum losses you could have. So Medicare is pushing, remember the goals, they are pushing ACOs more quickly to downside risk, but they are offering a more shallow glide path and a more limited risk by limiting the maximum risk for all of the basic track to only 10% of your benchmark, where currently tracks 2 and 3 would be 15 and 20%. Okay, we can go on. This slide is the next parameters. I'm not going to spend a whole lot of time on this, but this is the capping the liability for the shared losses at either 2, 4, or 8% of your expenditures. I'm going to come back to that in a minute. We can go ahead. Also note here that, and I pointed out before that all of the current two-sided risk ACOs qualified as advanced APMs. Under the new proposal, only basic level E and the enhanced track would qualify as advanced APMs. So a question is, why don't all the two-sided risk ACOs qualify like currently? Under the terms of the QPP, to be an advanced APM, you have to have downside risk, but you also have to have enough downside risk to meet the threshold of an advanced APM as defined in the QPP. Level E, the old track 1A, and enhanced track, the old track 3, meet those definitions. But because they've offered the ACOs these new level C and D, which are lesser amounts of downside risk, they're not enough downside risk to trigger being qualified as an advanced APM. But that's something that you should note. Another item to note here in the blue band in the middle is that all of the tracks in the new proposal will have a choice of beneficiary assignment methodologies. Currently, in the current program, there are two options. Track 1 and 2 use a prospectively assigned beneficiaries with a retrospective final reconciliation. The other ACOs use a prospective beneficiary assignment methodology. So there's been a lot of discussion and argument about which one is better and letting ACOs have their choice. So Medicare, the CMS is doing that here. Under any of these tracks, each ACO can on an annual basis decide which assignment methodology they want to use for themselves. So everybody will be able to make their own decision and to revisit that decision on an annual basis. That's a new item. Also, with the 5 levels of basic track and the enhanced track, this glide path or ladder, if you will, there are restrictions to where ACOs are going to start on the ladder. All of the folks on the phone are not going to start on level A. If you're an existing ACO, you're going to start at best, level B. And some ACOs will need to go right to level E or the enhanced track, and I'm going to explain that in a minute. However, if you are on the basic track, whatever level you're on, if you complete a performance year, in the next year you must move to the next level. So if you start at level A, and what a brand new ACO would get then for 2 years, level A and level B of one side risk, their third year they would be required to go to at least level C. You can skip a grade, if you will. You have to move up, but if you'd like to move up more than the minimum, or if you'd like to start higher on the ladder than the bottom rung or the rung that you're required to, you can do that on an annual basis. So, and you need to then progress through your contract from there. So if you started at level D, you would have 1 year at level D, and then you would move to level E. And I'll do a little bit more of that in a moment. Okay. So question is, where do each of the ACOs, and each one of you needs to understand for your organization where the options are for you. And there's 3 factors that are being taken into account to decide where on the ladder your ACO is allowed to start, the lowest rung it may start on. First is ACO status. If you're a new ACO, and the definition is you're entering the MSSP for the first time, and we're going to visit what new means. Renewing means that you have a current contract and you're going to renew into the new program. Re-entering is an ACO that had a contract in the MSSP, had a break in participation, either voluntarily or not, left the program and is now coming back. So they're coming up with 3 groups. Now, new ACOs is hard to define. It's not just simply a new tax ID or a new corporate name. Part of the regulations that CMS is coming up with in one of the other provisions is they're trying to prevent gaming the system, as they call it. There have been a few ACOs, in order to maximize their time under one-sided risk, that have gotten to the end of their 3-year period, closed shop and reincarnated themselves under another tax ID and said, I'm a new ACO, I get to start at the beginning again. Absent the new proposed regulations, that would still be possible. However, that's no longer possible. Reincarnation is not going to work. So if you were to close your shop and simply then rename it under a new TIN and give it a new name, if 50% of your participating physicians and hospitals have participated in the same ACO before, and not necessarily your ACO, but any same ACO, somebody else's across the street. In other words, they have experience with this. They're not really new. You're going to be considered re-entering. You will not be allowed to be considered new if half of your doctors have already basically participated in the program. So they're getting rid of that reincarnation option. The second factor is your revenue ratio, and I've mentioned this already, low and high revenue. The revenue ratio is the ratio of, it's the proportion of the expenditures, Part A and B, for all of your assigned population that was paid to, or the services were performed by, tax IDs inside your ACO. So essentially what they're doing is they're separating physician-only ACOs from ACOs that include hospitals. Even if you, certainly no ACO performs 100% of the services in ACO for all of their beneficiaries. But if you only have physicians and even a well-rounded network, you're probably still only providing less than 25% of the care for your patients directly. All the rest of the care to hospitals and DME and labs and all of the other providers out there. But if you've got hospitals in your network, you're probably over the 25% threshold. So Medicare set this on purpose. Again, they believe that there is a difference in performance between physician-led or physician-only ACOs and those that include hospitals. And I can't defend it, but they even believe and have gone far to say that the high revenue ACOs stifle competition. So I'm sure there's lots of opinions, disagreeing opinions with that. But Medicare has put this forward and is using this. You'll see how that gets used in a moment in terms of the options on the glide path. The third factor is the experience level of the ACO and its participants. You will be considered inexperienced if the ACO legal entity has not had any performance-based Medicare at risk. You've not been in the MSSP before or any of the other CMMI initiatives. And less than 40% of your participants, excuse me, have participated in a two-sided risk initiative. So turning it around, if your ACO has participated in risk initiatives, or more than 40% of your participants have already been at downside risk, you're experienced with downside risk and you'll be considered an experienced ACO. So a track 1 physician-led or physician-only ACO would generally be inexperienced. No downside risk for the ACO or its participants. So taking those three factors together, what does that mean? What implications are there? First of all, low revenue ACOs can participate in the basic track for 2 agreement periods, which do not need to be consecutive. One of the things is that another change that's being made. Currently, the agreement period is a 3-year agreement period. CMS is proposing to make that a 5-year agreement period to give everyone more stability. So what that means is that a low revenue ACO could actually stay in the basic track for 10 years. Now, there's still the rule that you have to move up the ladder each year. So if it was a brand new ACO starting at level A, they would go through their first 5 years, A, B, C, D, E, and the second 5 years would all be at E, since they were already there. You move up, but you don't go backwards. So now I said it does not need to be consecutive. So the only opportunity to go backwards, if you're a low revenue ACO, you finish your first 5 years under basic, and you say, we're ready to go to enhanced. We want to jump there now. And you start that, and you realize that it's a mistake. You can actually go back to the basic track because you still have your second 5-year agreement period that you haven't used up. I've explained it's sort of akin to your college sports eligibility. If you drop out of college in the middle, you could re-enroll in college and you still have years of eligibility to play sports. Sort of the same kind of concept. If you don't use them up consecutively, you still have that in your back pocket. Now, you can only do that after your first turn. So if it's not consecutive, it would have to be your third. You can't go to enhanced for 3 or 4 periods and then decide to go back. But in your initial period of enhanced, if you realize that's not for you, you have one opportunity to go back and get another 5 years under basic. Now, and then inexperienced high revenue ACOs would have to transition to the enhanced track after 1 agreement. So just the low revenue ACOs get the second one. Everybody else will get 5 years under the basic, and then you go to enhanced. And that's it. So you progress through the basic, and then you go to enhanced. So over time, all the ACOs will end up in the enhanced track after you've been in the plan for a while. That's where CMS is pushing everybody to get to track what was now track 3. So to summarize all that and make it a little easier to follow, I built the following 2 tables here. So for a new ACO, and remember the definition, new including not reincarnated, truly a new ACO, if you're inexperienced and truly new, you can start at basic level A. You start at the bottom of the ladder, and you can get your full 5 years going A, B, C, D, E. If you are experienced, either the ACO or your participants are currently in tracks 1A, 2, or 3, you have downside risk experience. You are an experienced ACO, and therefore the minimum you can start is basic level E. If you're low revenue, if you're high revenue with hospitals, you go right to the enhanced track. Done. Okay. Now, for renewing or re-entering ACOs, that's most of the people on the phone, I assume, that you're currently in the program, so you'd be renewing. If you're experienced with downside risk, those of you at downside risk now, again, you're going to either join the program at level E, the old 1+, or an enhanced track, the old track 3. You're going to stay you're at downside risk now, you're going to stay at downside risk under one of those 2 options. If you're inexperienced, you can start at level B. So essentially the difference there for inexperienced ACOs, those of us in track 1, who is 92% of the ACOs, if you're a new organization, you start at level A. If you're an existing track 1 ACO, you're going to start at level B. So if you've maximized out, and I'm going to get to this as well, or are maximizing out your second 3-year agreement, under this new program, you will get one more year of upside only in level B. That'll be your 7th year, if you will. You'll get one more year, and then you're going to go to a minimum of level C from there, unless you choose to jump up the ladder and skip a grade. So you get one more bite at the apple under the new program. So again, all of this is CMS's way. Remember the goals. They want to push everybody to downside risk where they believe all the savings are coming from. But they are giving a glide path to that and are giving some concessions. But staying in track 1 forever is not an option. Staying in one-sided risk. Now, at the most going forward, be 2 years for a brand new ACO. Okay, so that is the participation options. That is the major change proposed. There are, however, a large number of other provisions that are proposed that I'm going to just mention briefly. You need to know about them. There simply isn't time in a 1-hour webinar to cover all of the provisions. It's such a comprehensive proposal. First thing I want to let everybody know is the timing. All of the ACOs have been very anxious, especially those that need to renew for 1/1/19. The application materials didn't come out, and we were waiting for these proposed changes. There will be, under this proposal, there will be no renewals for 1/1/19. That open enrollment, if you will, is canceled. The next opportunity to either enter the program or renew will be July 1st, 2019. So what does that mean to those of you who have current contracts? If you have a current contract that expires at the end of this year, you will be allowed to extend it for 6 months until July, until the new program goes. So if you're in track 1, you will actually get 6.5 years. Under track 1, you'll get a 6-month extension to tie you over until July 1st. If you are not in the last year of your agreement, you will be allowed to run that agreement out. CMS is not canceling your agreement. So if this is your first year of your track 1 agreement, you can run it out through 2019 and 20, and then 1/1/21, you will then renew under the new program. So you have the opportunity to run out your contract if you choose to do so. You may decide to terminate that contract early. If you like this and you want to jump into the new program early, you will be allowed to terminate your current program and renew under the new deal. So all of this is going to happen there. So what's going to happen there is, if you think about it for a minute, we're going to have a bunch of ACOs that extend their contract and are going to end up with a 6-month performance year. You have to say that. That's actually a sentence I have to say. There'll be a 6-month performance year for that extension. And for those jumping into the program new on July 1st, the first year in the program will be a 6-month for the rest of 19. So for those of you who jump in on July 1st, I said it's a 5-year agreement period. Those of you who jump in July will actually get a 5.5-year first agreement period. And then all the next ones will be 5 years. But what that leaves is two groups of ACOs with 6-month performance years, some on the way out, some on the way in. How do we deal with that? The short story, without going into the whole thing, is that Medicare is going to calculate the savings and the performance on a full calendar year basis as it does now, and then prorate the savings or the losses for the 6 months out of 12, so 50%. So if you stay in if you extend for 6 months and then flip over to the new program, 2019 will actually be 2 6-month performance years. The first 6 months, but we'll use the same base results for the whole calendar year, but the first 6 months will be judged under your old contract at 50% savings, etc. And the second 6 months will be judged under the new program at 25% savings, etc. So we use the same calendar year results, both looking forward and backwards. So very complicated. Now, quickly, I'm just going to give mention to some of these other provisions, all important, all items that your ACOs should get a full grip on. Voluntary alignment was something that was started this year. Beneficiaries can contact Medicare and choose the primary care physician that they want to be there, aligned with them, and therefore that will supersede the attribution process and the algorithm that CMS uses to assign to an ACO. That opportunity for voluntary alignment is going to be allowed to all ACOs, and currently the only opportunity is to align, the beneficiary can align themselves with one of the physician types that is used in the formula, which is basically primary care physicians and a select list of specialties. Now it can be any physician anywhere. So there's no more restriction on the type of physician that it can be. So beneficiaries can get tied to your ACO. If they want to name, God forbid, they want their podiatrist to be their primary care physician, they can do that. And if that physician is in your ACO, they will be aligned with you. The benchmarking methodology is going to be refined. The quick story there is that the move to regional benchmarking is going to be continued and improved. And there's definitely some improvements there. I could do a whole webinar just on the changes to the benchmarking, and maybe that's something we'll do in the future. Monitoring of financial performance. I do want to mention this. They are going to put more scrutiny to this. With Medicare's attitude, if you will, towards the program, they want successful ACOs, they want savings. So they're having this push to downside risk. But they're going to watch your performance. In the regulations, in your 5-year agreement, if you have shared losses 2 out of the 5 years, CMS can terminate your contract for cause based on that information only. So they don't want ACOs sitting in the program continually having losses and dumping those on the trust fund. So if you're going to be a continual loser, they don't want you. Now, I don't know how long you'd want to stay in the program yourself if you were continually losing money and writing checks back to CMS, but they've added that in now, that they've drawn that line in the sand. Again, there's a number of other measures that are listed here. I'm not going to go through those with consideration of time, but there's a number of other important changes that are proposed here that you can see here, and I talked about beneficiary assignment, etc.
Okay, thank you, Mark. I'm going to pause for a minute, do a second poll. Is your ACO likely to continue to participate in the Medicare ACO program under the proposed regulations? Everyone, give me a second. I'm going to launch the poll, and I'll share the results. Give everyone about 30 seconds to answer. Okay, thank you, everyone. I'm going to close it up. So 60% picked extracting data from multiple sources.
That's the wrong question. That's the answers to the other question.
No. I apologize, everyone, if this was. Sorry about that, everyone. You know, I made a mistake here. I have the wrong answers to the question. We're just going to move on, and yeah, we have one more. We have one more question coming.
All right, apologies for that.
Sorry about that.
I would like to know. We'll come back to that. All right, let's move on. Okay, so the impacts of this, what does Medicare and what do we, Spectrumetics, and we on the outside expect to happen here? Medicare is expecting a lower volume of ACOs going forward, a lower volume of new ACOs. As we said, a new ACO in the current program could look forward to 6 years of learning experience under upside only risk, sharing 50-50. Under the new program, 2 years sharing 25-75. So there's less attractive to new ACOs, clearly. Some of the existing ACOs will make a decision not to participate under the new program. And their Medicare is anticipating some effect of that. Altogether, they think about 20% of the ACOs will go away, or there'll be 20% less over the next 10 years. That's their estimate. A little over 100 ACOs. We've got 561 of them, I guess is the right number currently. However, NACOs, the National Association of ACOs, I'm sure many of you are members, has been polling its members for some time. And last May, they did a poll that if you were forced to go to risk, would you continue under the program? And a little over 70% of the Track 1 ACOs said no, they would not. So somewhere between 70% right now and 20% over 10 years, that's a pretty big difference. I think the real answer, obviously, is somewhere between the two. But clearly, not everybody is ready to go to downside risk, and there will be some ACOs that leave the program. CMS is expecting that and actually encouraging that. They think that they're going to cull the herd and get left with a group of ACOs that, in Seema Verma's own language, are serious about accountable care and want to generate savings for the trust fund. So that's what's going to happen there. So they expect all of that to generate greater savings for the trust fund as we go forward. Now, let's question some of the assumptions that gave way to CMS's policy advisors here. This is the chart I showed earlier with the savings to date for the net savings for the MSSP, but I've added in 2017. What has occurred is that when CMS released the proposed regs, they only had the 2016 information. And actually, between you and me, I think the correct way to say that is only the 2016 had been released to the public. Because shortly after this was proposed, the 2017 results were released. And I have to believe, this is my personal opinion, that CMS understood what those results were going to show well before they were released to the public. But presumably they didn't have that information to advise their decisions. The good news is 2017 was a banner year for ACOs. Altogether, gross savings were $1.1 billion. Net of the shared savings payments, there was a savings to Medicare of $314 million. So finally, measurable net savings and significant. I think if you look at that blue line, it's showing what most of us have been saying is that ACOs work, they do generate savings, but it takes time for a new organization to learn how to operate under the program and to put all the clinical and administrative procedures in place to be successful. And if you look at this, you see that in year 3, when we hit the high there, but after years 4 and 5 are showing very significant progress. To me, that tracks very well with 6 years of upside only, that if we work through those 6 years, ACOs coming out the other end should be very efficient and operating. Of course, CMS has not reacted to those 17 results in terms of their proposal. But I'm sure a lot of the comments that are being submitted are reminding them of that. I would love to see how that changes their policy proposal, if at all. Now, all of that is using the definition of savings as what we use for the benchmark and what's used for performance measurement for shared savings. That is not necessarily the best way to judge the program, whether it's working or not. NACOs, realizing that, engaged an outside vendor to do a separate study of the savings. And without going into the long review of the study, basically looked at the costs of beneficiaries who were assigned to ACOs versus other fee-for-service beneficiaries that were not assigned to ACOs on a national basis and compared their two costs of the two groups. That's quickly a summary. They did a regression analysis and compared the costs of the two groups, controlled for differences in risk and age and sex and geography, tried to control for those effects. The green line on this chart is the estimate of NACOs. They're actually saying that the gross savings to the program are $1.84 billion, which is double what Medicare says of gross savings of just under $1 million. On a net basis, looking at the cost of ACO beneficiaries to the NACOs, they're estimating that over the course of 2013 to 15, the data that was available for analysis, ACOs have saved the government actually a total of $542 million that the beneficiaries in ACOs are spending less than those not in ACOs. That is a more statistically appropriate way to measure savings of the program. The performance, the benchmarks, and the shared savings are wonderful for deciding on the amount of a bonus, but it does not capture all of the savings generated by the program. So NACOS has done this study. They have released the results. If you go on their website, you can get their results. And they've also shared those with CMS as part of the official comments on the program. So we'll see how CMS reacts. So this flies in the face of one of the main reasons for these changes is that the program hasn't saved any money yet to date. Certainly the 2017 results in CMS's own world conflict with that, and then the way that NACOS has measured savings completely contradict that. So there's certainly some controversy there. So if the assumptions are not correct, therefore are the policy changes the right changes that we should be making? Also, we did our own analysis of the results here, and we looked at the results for 2017 by track. And I just do this real quickly because we're running out of time. one of Medicare's assertions is that the at-risk tracks 2 and 3 are generating more savings than the track 1 ACOs. First of all, that's not true on an aggregate basis. The track 1 ACOs are 92% of all the ACOs currently in 2017 and generated 92% of the net savings. So they held their own. But if you look at it on a per beneficiary and per ACO basis, which we did, and Medicare doesn't seem to have done, the track 2 ACOs outperform the other 2 tracks, but there's only 6 of them. And actually, if you look deeper, 4 out of the 6 had savings and 2 did not. So it wasn't even all of them, but there were some very big winners in track 2, which skewed the results, and with only 6. But credit to track 2, they did a good job as a group. However, you'll see that on both a per beneficiary and per ACO basis, track 1 outperformed track 3. Actually, in savings back in terms of Medicare's own methodology. So I offer that as evidence that the track 1 ACOs are working, are generating savings if you look at the numbers fully or correctly, whatever word you might fill in there. So there is some evidence and some controversy over how successful the program has been to date. All right, given all of that, my suggestion to each of the ACOs listening in, you need to go back to your boards and your committees, and there's a few key things you need to consider about the new Pathways to Success program. If you're not in, do you make a decision to jump in the program? Most of you on the phone are already in. Do you continue under the program, or do you discontinue your relationship under MSSP? If you've got a current agreement, do you continue to run it out to its end? If it's running out this year, do you extend it for 6 months, or do you terminate? ACO tracks, you're going to have to go back over the information you learned here today, understand which tracks are open to your ACO in your circumstances, whether you'll be considered experienced or new or inexperienced or re-entering or wherever you fall. What are the options and where would you like to be? Given those options, you need to understand what's permitted and what you'd like to do, what you'd like to desire to do. The two-sided risk corridor, I didn't mention that earlier, but you get a choice under the new program of different risk corridors. That is a choice of the minimum savings rate and the minimum loss ratio, that risk corridor between where you get shared savings and shared losses as opposed to not sharing. There are 2 options: the population-based approach used by track 1 ACOs now, where that number, the corridor gets smaller as you get larger, and then there's the symmetrical choices open to other ACOs. You're now going to have a choice of which method you'd like to use. As I mentioned earlier, you get a choice of prospective or retrospective assignment. There's also expanded opportunities for the skilled nursing facility 3-day waiver. You're going to decide if you'd like to participate in that. And there's also increased opportunity, a new opportunity to actually offer small cash incentives, a beneficiary incentive program to your ACO assigned beneficiaries to encourage them to complete necessary medical care, generally primary care. So you can actually offer bonuses for people who get their immunizations, do their annual wellness visit, etc. So you've got to make a decision about whether you want to jump into that. So again, there's a lot of things in this proposal that I couldn't hit today. But to wrap up, you've also, in order to make all those first decisions, you've got to evaluate the state of risk readiness of your ACO. And the big areas there are, can you take in the data, integrate all the data that you need from the various sources? Do you have the proper data analytics? Are your physicians and patients engaged? Have you achieved the level of clinical integration among your members? Can you take into account the social determinants of health, et cetera? So those are the things that we help our clients with. We just are suggesting that everybody take a step back and evaluate themselves in terms of where they are, because if it doesn't get completely debunked, this proposal is going to go forward, and risk is coming under this new deal.
All right, thanks, Mark. So we're going to do our final poll here. Hopefully we have the right answers queued up. What are the most challenging issues facing your ACO? Okay, we're going to give everyone about 30 seconds to answer. Okay, thank you, everyone. I'm going to close it and share the results. So data integration analytics, big data is the biggest challenge by far, 62%, followed by physician engagement and clinical integration. Thanks, everyone, for participating.
Thank you.
We're going to do a few questions now.
We've
had a number of them come in. Give me a second here. So,
what is the MSR and MLR? Okay. In the tables that I presented on the current tracks and the new tracks, I did use the term MSR and MLR. MSR is minimum savings rate. That is the minimum percentage of savings that you have to achieve before you get shared savings. And MLR is the minimal loss ratio. On the other side, what's the minimum amount of losses you have to generate before you have shared losses? So together, those two items define what I've called the risk corridor. The amount of savings or losses that you have to achieve before you share in those items. Okay, what else do we have?
I think this is a good question here.
Can you read it for me? I can't read it.
2019 will be our 6th year in track 1. We are inexperienced because we haven't had downside risk. So it sounds like we will be able to stay in the basic track, level B, for 1 year before going to level E.
That's right. So if 2019 is your 6th year, you will be able to finish. So this year is your 5th year, your 2nd year under your 2nd agreement. You'll be able, if you would like to, you can finish 19 and finish your 6th year, and then you will be able to, on 1/1/20, join Pathways to Success under basic level B and get one more 7th year under upside only risk. That is correct.
All right, so we're running out of time. We'll take one more here. My ACO is in the 2nd year of our
That's the
3-year.
same question.
Oh, yeah, okay. So we'll do here, this one. In the table of participation options, I noticed that the options vary for new ACOs that are inexperienced or experienced. How can a new ACO be experienced?
Right. So there actually is, if you look at the tables, how can a new ACO be experienced? Again, because definition of new and experienced both look at not only the entity, but the participants, the physician and hospital participants. To remind you, to be a new ACO, less than half of the participants have to have come from another ACO. So if more than half of your participants were together in another ACO before joining your quote unquote new one, you've got an experienced participation set of participants, and so your ACO is new. And then on the experience side, to be inexperienced, you have to have less than 40% of the physicians have participated in downside risk in the last 5 years. So with those definitions, and again, that's for the anti-gaming purpose, there is a possibility that an ACO could be determined to be new but experienced, so that they had less than 50% of the participants were together in the same ACO, but more than 40% of them were in two-sided risk somewhere, scattered around. So there actually is an opportunity for you to be new and experienced at the same time.
All right, thank you, Mark. So we want to be sensitive of time here. We're past the hour. We've had additional questions come in. We will reach out directly to anyone who has asked a question here today that we did not get to. Additionally, if you have any other questions or would like to learn more about us and our product, or if you have any questions for Mark, please reach out to him. His information is on the screen right now. You can reach out to myself as well, nathan.brown@spectrumedics.com, or my phone number is 609-638-2987. We're going to be sending out some materials as follow-up to the presentation today, so expect to see them in the next day or so. And if you have any questions, please let us know. Thank you for joining today. This was a great presentation. Thank you to Mark for all his work and helping put this together. And we hope everyone has a great rest of their Thursday.
I hope you all learned something and have a good day.
Thank you. Take care.